Bismillahir Rahmanir Rahim. My name is Muhammad Ibrahim and I'm lecturer at the University of Hargeisa. In this presentation we are talking about the thyroid ultrasound. We will discuss anatomy of the thyroid gland, scanning techniques, nodular thyroid disease, sonographic features of benign and malignant lesions, and diffuse thyroid disease. The thyroid gland is a very superficial gland, consists of right and left lobe located either side of the trachea and a connecting isthmus across the midline. A pyramidal lobe is present in 10 to 40% of normal patients. It's a finger-like lobe of tissue which extends superiorly from isthmus and is of variable height. The normal thyroid gland has a wide range of size. Lobes are normally equal in size. In normal adults, it measures 40 to 60 millimeters in length, 20 to 30 millimeters in AP diameter, and 13 to 18 millimeters in width. Thyroid volume might be useful to determine the size of the goiter to assess the need for surgery or to evaluate the response to suppression treatments. The method commonly used to calculate thyroid volume is based on the ellipsoid formula, which is length times width times thickness times 0.52. The normal mean thyroid volume is 18.6 plus or minus 4.5 milli. The volume in males is slightly greater than in females. Relational anatomy. Along the anterior surface of the thyroid gland, there are strap muscles. Here are sternohyoid muscles, appears as a thin hypoechoic band anterior to the gland. Here is the sternocleidomastoid muscle, appears as a large oval band that lays anterior and lateral to the gland. And here is the sternothyroid muscles. Posterolaterally, here is the common carotid artery, internal jugular vein. Here is the longus colli muscle, appear as a hypoechoic structure adjacent to the cervical vertebrae. Posterior-medially, this is the esophagus, appears like a target on transverse plane, and here is the trachea. Sonographic techniques. The thyroid gland should be examined with a high frequency of 7.5 to 15 MHz linear array transducer. Patient is placed in supine position with a pillow under the shoulders to provide hyperextension of the neck. Scanning should be done in a sagittal, transverse, and oblique planes to optimally visualize the common carotid artery, internal jugular vein, both lobes of the thyroid, as well as the isthmus. This is normal thyroid gland, homogeneous echo texture that is slightly more echogenic than the surrounding muscle. This is the thyroid capsule. It is thin, hyperechoic line that clearly outlines the gland from other structures. The role of thyroid ultrasound might be resumed in three main issues. Number one, to detect thyroid and cervical masses. Number two, to differentiate between possible benign and probably malignant masses based on their sonographic appearance. Number three, to guide the performance of fine needle aspiration biopsy and percutaneous treatment. Thyroid ultrasound is able to provide answers to several clinical questions. Is the palpable mass within or adjacent to the thyroid? Is the tumor confined to the thyroid or locally in various nearby structures? Are cervical lymph nodes involved? Is there a primary focus in the thyroid gland in a patient with cervical adenopathy? Is there a post-operative residual or recurrent tumor in the thyroid bed or metastasis to the neck lymph nodes? Then let us go to the pathology of the thyroid gland, and we will begin with a goiter. Any form of thyroid enlargement is called a goiter. It is the most common thyroid abnormality. Goiter or hyperplasia starts at the cellular level, leading to formation of micronodules and macronodules. These nodules then undergo necrosis, which result in accumulation of blood, serous fluid, and colloid substance. This is called hyperplastic adenomatous and colloid nodules. So many cystic thyroid lesions are hyperplastic nodules that have undergone severe degeneration. This process may be associated with euthyroid, hypothyroidism, or hyperthyroidism. Benign lesions. Nodule is one or more area of the thyroid with a different echo texture than the surrounding parenchyma. The prevalence of palpable thyroid nodule in adults is 7 to 21%. On ultrasound, it has been demonstrated in 40% of asymptomatic patients, and by autopsy, thyroid nodule is around 50%. Therefore, physical examination alone is an insensitive method for detecting thyroid nodules. More than 80% of nodular diseases are found to be benign and not need for biopsy. Benign thyroid adenoma comprise 10% of focal nodular disease, and only 5 to 10 are found to be malignant. So the role of ultrasound is to evaluate nodule and indicate whether biopsy is necessary. And the challenge is to reassure the majority of patients who have benign nodular disease and diagnose the minority malignant. Cyst in the thyroid gland is thought to be cystic degeneration of a follicular adenoma. Its appearance on ultrasound corresponds to their degenerative changes. As with all simple cysts, it must be anechoic with a sharp, well-defined walls and posterior enhancement. Follicular adenoma is a benign tumor of thyroid follicles. It is usually a single, well-encapsulated lesion. The other area of the gland appears normal. Sonographically, adenoma has a broad spectrum of appearance. It can be hypoechoic, isoechoic, or hyperechoic to the normal thyroid tissue. Most adenomas are solitary, solid, homogeneous lesions with regular margins and oval or round shape. They tend to undergo cystic degeneration. An echoic peripheral halo might be seen within adenoma. However, this halo might also be present within malignant lesions and is therefore non-specific. Adenomas may also have localized peripheral calcification or may be entirely calcified, resembling a calculus. This is an example of adenoma, solid, well-defined in mass with hypoechoic halo. This is another example of adenoma undergone cystic degeneration. Malignant lesions. Carcinoma of the thyroid is rare. Small percentage of single nodule might be malignant, but when it is multiple nodule, the risk will decrease more. Most thyroid cancers are relatively non-aggressive and have good prognosis, with 90% 10-year survival for early disease. Papillary carcinoma is the most common type of the thyroid carcinoma. It comprises 70 to 80%. The next most common is the follicular carcinoma. The other types of medullary, anaplastic, and lymphoma are rare. Papillary carcinoma is 2 to 3 times more common in women, also more common in young patients between 25 to 35 years. Radiation exposure, especially in the childhood, is a major risk factor. Sonographically, papillary carcinoma is hypoechoic in 90% of cases. Microcalcifications are seen with or without posterior shadowing. Hypervascularity is noted on color Doppler. Approximately 20% of cases show lymph node metastasis. This is an example of papillary carcinoma, 7.8 millimeters, hypoechoic nodule, speculated margins with microcalcifications. This is another example of typical papillary carcinoma, solid hypoechoic tumor without a capsule. Here we see ill-defined margins even infiltrating into the parenchyma. These are small calcifications in the solid area without shadowing due to its small size. This is a cystic papillary carcinoma. It's not completely cystic, it's predominantly cystic. There are here areas of solid parts with calcifications. And this is color Doppler showing hypervascularity. Follicular carcinoma is the second most common type of the thyroid cancers, well differentiated and develops from follicular cells. It is usually solitary and more aggressive than the papillary carcinoma. Some of them are well encapsulated, less invasive, whereas others are not encapsulated, which means widely invasive tumor. Sonographically, it may show irregular margin with thick, irregular halo and tortuous internal blood vessels. This is an example of follicular carcinoma. It is solid, hyperechoic, with irregular, thick halo. Medullary carcinoma accounts for 5% of thyroid cancers. It is often familial and essential component of the multiple endocrine neoplasia type 2 syndrome. High incidence of metastatic involvement of the lymph node has been reported. This is an example of medullary carcinoma. Appears like a papillary carcinoma, solid, hypoechoic with multiple calcifications. And this, the lymph node of the patient appears as a round, hypoechoic, suggesting metastatic lymph sign. Now we are going to discuss characterization of the thyroid nodules. These characteristics are well-documented signs that can be used in differentiation of benign from malignant. Identifying these relevant signs of benignity and malignancy in the thyroid nodule can be used to provide helpful ultrasound diagnosis and decide which nodule should undergo biopsy. We will see size, texture, margins, presence or absence of halo, calcifications, vascularity, and lymph nodes. The size of the thyroid nodule is not helpful to distinguish a malignant from a benign nodule. The nodule size should be precisely documented for a purpose of follow-up. Although in principle the size of the thyroid nodule should be measured in all three dimensions, only the maximal diameter of the nodule can be measured and documented. When measuring the nodule, it is advised to locate the calibers at the outer margin of the halo of the nodule. According to the American Thyroid Association guidelines, a reasonable definition of growth is a 20% of increase in the nodule diameter with a minimum increase in 2 or more dimensions of at least 2 millimeters, which is roughly a 50% increase in the volume. Although malignant is believed to grow more prominently than benign, but even benign nodule can grow with the time, and about 90% of benign nodule have demonstrated an increase in volume by 15% over a 5-year follow-up. Cystic nodule showed slower growth than the solid nodule. We can see in this study 150 nodules reported as a malignant on fine needle aspiration. 83 of them were less than 1 centimeter, whereas 67 of them were more than 1 centimeter. On the other side, 823 were diagnosed as a benign. Almost 45% of them were less than 1 centimeter. The other 55% of them were more than 1 centimeter. The mean diameter of the benign nodule was 12.1 millimeters, and the malignant nodule was 10.6 millimeters. So the size of the nodule is not as significant in differentiation between benign and malignant nodules. The next characteristic is texture and echogenicity of the nodule. It can be hypoechoic, isoechoic, or hyperechoic. Also, it can be solid, cystic, or mixed. Most of the cancers are hypoechoic, but the dilemma is that also most of the hypoechoic lesions are benign, because the most common thyroid nodules are benign. So there must be another features. Hyperechogenicity is a strong feature of benign nodule, especially if associated with cystic area. Also, if nodule is uniformly hyperechoic with thick halo, it favors malignancy. This is an example of solid hyperechoic nodule with cystic area, suggestive of benign nodular hyperplasia. This is another example of solid nodule, but in this nodule it is homogeneous and uniform in addition to the thick halo. This suggests malignancy. This is a typical hypoechoic solid nodule with irregular margins showing high probability of malignancy. This is predominantly cystic nodule with area of solid parts and calcifications in it. When color Doppler was on, the solid parts showed follow, and as we mentioned before, nodular hyperplasia may undergo cystic degeneration, and usually it contains solid parts. But what makes it different is the calcification and vascularity in the malignant nodule. And this is cystic nodule with echogenic foci in it. Here we can see common tail artifact behind the foci, and this typical colloid nodule. This is a sponge-like nodule. It is a multiple cystic of thin septations. This indicates benign non-neoplastic nodule. The other sign to observe is the calcifications. Calcifications are found in around 1/3 of the thyroid nodules. It is common in both benign and malignant disease, but the risk of malignancy will be high if it is found in solitary nodule and if it is punctate or microcalcification. Microcalcifications are less than 2 millimeters. It is two types. Type 1 with common tail artifact. It is usually found in a cystic nodule or complex nodules. It is thought to be thyroid globulin concentration. When calcification with common tail artifact is seen, it is strongly indicated to be benign. The other punctate type of the calcification is worrisome. It has no common tail artifact. It is here without distal acoustic shadowing. So whenever we see a punctate calcification with no common tail artifact, we should biopsy it. Coarse calcifications are more than 2 millimeters in size, usually common in multinodular goiter. It is worrisome if it is found with a solitary nodule or nodule with mixed nature or associated with other microcalcifications. This is a solitary nodule with a coarse calcifications and many other microcalcifications. This is another example of coarse calcification in infiltrating hypoechoic solid nodule. There are also other microcalcifications suggestive of papillary carcinoma. This is a study published in January 2011. Over 4,000 patients were examined in this study. There were 1391 malignant cases. Calcifications were seen in 1725 patients, which is around 41%. The significant number here is that the incidence of malignancy was over 96% for patients with microcalcifications and 41% for patients with macrocalcifications. Peripheral calcification is defined as a bright echoes observed on the surface of the thyroid nodule with or without acoustic shadowing. Peripheral calcifications are one of the patterns of the dystrophic calcifications located around the nodule. It was generally thought to be more frequently associated with benignity. However, cases of papillary carcinoma associated with this type of calcification have been reported. In one study, 14 cases of surgically proven thyroid nodule with eggshell calcifications were reported. 6 of them, which is around 43%, were malignant, and all of these 6 were papillary carcinoma. 8 cases were benign, including 5 cases of follicular adenoma and 3 cases of multinodular goiters. Another study of 93 surgical proven thyroid nodule with eggshell calcifications showed almost 63% were malignant, and 36 of them were benign. All of the malignant nodules were papillary carcinoma, and benign nodules included 33 adenomatous hyperplasia and 1 follicular adenoma. This is well circumscribed isoechoic nodule with rim smooth curvilinear calcification, confirmed it is adenomatous goiter. Spherical hypoechoic solid mass with area of interrupted eggshell calcification. This was diagnosed as follicular thyroid carcinoma. This is another example of papillary carcinoma. Here it is circumscribed, but like an arc, curvilinear and irregular. Nodule is hypoechoic mass surrounded by a thin hypoechoic halo. The internal architecture of the nodule is not visible because of the marked posterior acoustic shadowing. On fine needle aspiration, it is diagnosed as papillary carcinoma. This is hypoechoic mass with a peripheral smooth curvilinear calcification. It is confirmed on fine needle aspiration. It is papillary carcinoma. The margin of the nodule is categorized as smooth, spiculated, microlobulated, or ill-defined. Earlier studies have reported that spiculated, microlobulated, and ill-defined margins are suggestive of malignancy. Spiculated means jagged edge with sharp demarcation. We call it poorly defined and ill-defined margins when the nodule cannot be differentiated from the normal parenchyma. But also benign thyroid nodule, also known to be incompletely encapsulated and poorly marginated, and they can be merged with normal tissue. Therefore, an ill-defined margin is a non-specific finding that can be seen for both benign and malignant nodules. In contrast, a speculated margin is a highly suggestive finding of malignancy with a specificity of 92% and a positive predictive value of 81%. This is an example of well-defined encapsulated nodule with a thin halo suggestive of benign follicular adenoma. This is nodule of microlobulated and infiltrating margins suspected of malignancy. And this is solid nodule, well-defined in some area and ill-defined in another area. The halo is caused either by the capsule of the nodule or is due to the adjacent compressed thyroid tissue. It may be thin or thick. Thin and regular halo is seen in 60 to 86% of benign nodules and is usually seen surrounding hyperechoic or isoechoic nodule. It represents a compressed vessel. Thick irregular halo is a sign of neoplasm. It is believed that nodule is compressing adjacent tissue, and because of lazy nature of the thyroid cancer, this tissue manifests itself as a halo surrounding the carcinoma. Absence of the halo is more suggestive of malignancy. This is an example of thin halo surrounding adenoma with cystic degeneration. And this is halo surrounding solid homogeneous mass indicating follicular carcinoma. In terms of vascularity, there are generally three patterns of vascular distribution within the thyroid nodule. Type 1, complete absence of flow signal within the nodule. Type 2, exclusive prenodular flow signals. Type 3, internodular flow with multiple vascular poles with or without significant prenodular vessels. Type 3 patterns is generally associated with malignancy. Type 1 and Type 2 are more commonly seen in benign hyperplastic nodules. But as the other characteristics, if vascularization is used as the only predictor of malignancy, it will not be accurate. It should be used in combination with the other features. This is Type 2 color flow pattern with solid hyperechoic nodule. And this is Type 3 flow pattern, internodular flow in hypoechoic with irregular margins and calcifications. The last characteristic is the lymph nodes. Normal cervical lymph nodes are rarely visualized by ultrasonography. However, hypoplastic lymph nodes appear in many diseases and they are seen with high accuracy. Benign as well as malignant lymph nodes have typical sonographic morphology. Benign lymph node appear as an oval hypoechoic with a smooth border and hyperechoic hilum, which represents hilar fat and small vessels. Malignant lymph nodes have different manifestations. It can be more round or heterogeneous structure, commonly hypoechoic with a loss of hilum, sometimes with cystic degeneration or calcification. On color Doppler, it shows increased flow, peripheral or disorganized flow. However, fine needle aspiration still remains the most promising tool for confirming or excluding malignancy. This is a review of the literature of the radiological science that can predict thyroid carcinoma. Many researchers proposed to use these criteria to identify the nodule which is more likely to be malignant and should undergo fine needle aspiration. Of all of these features, we have seen the solid hypoechoic lesions with microcalcifications is the strongest indicator of malignancy. Also, we can recognize here that predictive ability of ultrasound for a malignancy is effective only when multiple signs are present in the same nodule. Also, we can note that although their predictive value increase in summation, but their sensitivity will decrease. The spectrum of signs that are available in differentiation of benign and malignant thyroid nodules can be incorporated in radiological classification system similar to that used in the breast. Radiological classification of thyroid nodule are described as an R1, R2, R3, R4, and R5. R1 describes normal thyroid, no nodule is seen. R2 describes lesions that is probably benign. This is an example of R2 lesion. It is a cystic nodule with calcification is having ring down artifact. It is colloid cyst. This is another example of probably benign nodule, cystic, with peripheral blood flow. R3 describes indeterminate lesion. For example, this is a solid, homogeneous, and echogenic with well-defined halo. This is a follicular lesion, and 80% of these follicular lesions are benign. But the 20% of malignant may also have the same features, so we have to biopsy it. R4 describes suspicious lesion, means it has features of malignancy, but it's not strong enough to say malignant. Like this lesion, it is hypoechoic and homogeneous, but the color Doppler shows peripheral flow. R5 indicates malignant lesions with more than one features of malignancy. Like this nodule, it is solid, hypoechoic with microcalcifications and irregular margins. Again, this is R5. It is a metastatic lymph node, cystic and solid areas with microcalcification. Finally, let us see Hashimoto's thyroiditis. As it is the most common form of thyroiditis, it is characterized by a destructive autoimmune disorder which leads to chronic inflammation of the thyroid. The outstanding feature is a painless, diffusely enlarged gland in a young or middle-aged female. The entire gland is involved with the inflammatory reaction, but enlargement is not necessarily to be symmetrical. This Hashimoto's disease, microscopically small lobules of lymphocytes separated by fibrous strands, and this is what we see on ultrasound, hypoechoic nodule with ill-defined margins representing lymphocytic infiltration. This is another example of Hashimoto thyroiditis, diffusely enlarged and coarsened parenchyma, multiple tiny hypoechoic nodules in both lobes. There is prominent echogenic septation against the hypoechoic background. So this is the classic appearance of Hashimoto thyroiditis, and it has a positive predictive value of 95%. Elastography is a new developed technique that estimates the stiffness of tissue by measuring the degree of distortion under application of external force. Elastography has been mostly applied in studies of liver and breast pathology. In thyroid gland, elastography has been applied to study the elasticity of the thyroid nodule to differentiate malignant from benign lesions. This thyroid elastography, the blue color indicating very soft area and red color indicating hard area. And this is a papillary carcinoma. The nodule is very stiff, appearing as red on color display, while the adjacent parenchyma is less stiffness, appearing as blue. In conclusion, in the clinical workup of a patient with a suspicion of thyroid pathology, ultrasound should be the first imaging test. When ultrasound demonstrates a nodule suspicious for malignancy, or there is history of radiation, MEN type 2, or thyroidectomy, fine needle aspiration should be the second diagnostic exam under ultrasound guidance. Thank you.